Welcome to the Healthcare Payment Network podcast. Why is paying and getting paid for healthcare so hard? Why is it unaffordable for most Americans? And most importantly, what are we going to do about it? Whether you're a provider or industry professional, ultimately we are all patients. This podcast is a conversation on how we tackle one of the most challenging problems in our society, paying for healthcare. Here we'll discuss new innovations and fresh perspectives from the people working to make paying for healthcare easier and more affordable. Let's dive in.
Hi, everybody. My name is Andy Rellihan, the Chief Commercial Officer at Payground. We are starting really a discussion or a podcast about healthcare payments. So there's a lot of frustration out there, both providers having to do a lot of work and not getting paid. Patients are confused. Their out-of-pocket expenses is skyrocketing. And there's a lot of innovation. There's a lot of new ideas. There's a lot of things that are happening to go solve those problems. So we're going to start having a discussion with industry thought leaders. And today we have Travis Gentry, the CEO of Hive Health. So Travis, do you want to go ahead and introduce yourself as we get started?
Thank you. I appreciate it. Travis Gentry, Hive Health. Got into this industry by accident 20 years ago. We started, pioneering patient estimation, which actually is a foundation for, I think, part of our discussion today, right? So it's kind of like farmers insurance. We think we know a thing or two because we've seen a thing or two when it comes to creating an estimate, and why we ultimately started, revisiting and watching no surprise billing and the good faith estimate. So thanks for having me.
Yeah. So maybe just to jump right in and start, what does the Hive Health solve for? And maybe talk about some of the industry problems that are out there surrounding what the Hive Health is at the center of.
So our view is really about aggregating data that does not organically or naturally exist in our industry. And part of that is around provider data in terms of creating a payer scorecard, helping providers be compliant with some of the CMS price transparency elements, to specifically with no surprise billing and good faith estimates. We look at that as the challenge of how do we help hospitals really aggregate estimates from providers who are outside of their organization. I think everyone looks at that as like, it's one thing for me to get estimates if I am the hospital and I have hospital-owned physicians, but how do I get information from those external physicians in my community that I normally would not have access to? And for the last 20 years, right, we've always disclaimed that, their participation in any estimate. So it's all about, whether I'm aggregating data and data just from claims remits, reimbursement information to estimates. So thematically, it's all very similar as, kind of the Hive concept.
Sure. And you had kind of two different components to that. One, the payer component, and one really around the patient component. And so just to kind of start with the patient component in a GFE, just for everybody listening, what is a GFE? And regardless of policy or legislation, why is it a good thing? And how do you think, wider adoption could help the industry and patients' understanding of what their medical bills are?
Today, patients, I think, have this expectation that they should be able to get an estimate for everything that's part of their total encounter of care. And I think the technology and the workflow and everything just being built over the last, couple of decades has been looking at this, piece by piece and saying, well, here's the hospital estimate or the surgical center estimate, right? Maybe we're starting to get estimates from physicians or, the surgeons. But then everything else, and part of the reason why no surprise billing, act came about, right, was because patients have historically been surprised by all these other bills, whether, it gets into this in-network versus out-of-network component. But today, it's the way that we as patients, when we look at ourselves as consumers in all other industries, right, we have this ability to understand what all of my costs are. But yet when we come into healthcare, right, we seem to step back into the Stone Age where all of a sudden, like, that's not possible. And
Yeah.
that, I think that's part of why it's so relevant today, is that with technology in every other industry, this is something that we can do. It's just a matter the industry is not quite prepared to do it. But the technology is quickly advancing, the processes are evolving, and I think people are coming to the realization that it's the right thing to do for a patient.
Yeah, no, it's, as dad of four, I experienced that 4 times over, where you get a bill and then you get another bill and then you get another bill and you get another bill. And sometimes it happens, 6 to 9 months after our kiddos crawling, and then we get another bill,
Yeah.
and it's kind of crazy that, yeah, you pair that with any other industry of expectation of what you're going to spend, and it's really, really hard to wrap your arms around.
No, I
And there's
think,
people beyond baby, just chronic disease management, severe things like cancer, major surgeries. I mean, it just, you know, it it really is a difficult challenge.
no, I think there's a lot of what I call this learned helplessness in our industry. And I think part of that is just because we get focused on the things that we think that we can do. And, these hospitals and providers in general, I mean, are absolutely trying to do everything that they can to provide the very best care for patients, right? So clinically, absolutely. I think that sometimes it's getting all the right information at the right time, to answer some of these questions or to set expectations, which has been the challenge, right? I mean, to your point, we have such latency in billing, right? To the point where it's not weeks, it's months after the fact that we start talking about these bills. And we're trying to do everything we can to move that further and further up into the revenue cycle so that, when a patient, is, just shopping to going through a pre-scheduling or scheduling, exercise, that's when they really need to know this. And we just have to adjust and have the right data available to ask those questions so that we can say, Andy coming in for his knee replacement, you've either, whether you're self-paid, you've got insurance. These are questions that we can ask. It's just a matter of having the technology to kind of simultaneously ask all of the providers involved, the exact same question to create a GFE.
Yeah, and you mentioned, the technology is advancing. The capability feels like it's there. What do you think the blueprint or maybe the barrier is to getting there, right? Because intuitively you could say, well, gosh, this just makes all the sense in the world. So what do you think's preventing it, and how do you think we get there the fastest?
There's always like the 3 elements, right? People, process, technology. I
Sure.
think the people want to do the right thing, but then they're limited by their processes, and then sometimes those processes are dictated by the technology. So you kind of have to hit it from behind, saying, well, let's look at the technology first, right? And say, how does that force a process to change? And then do the people have all the right information to enact that? And so again, going back to the last 20 years of hospitals just realizing that they could create estimates and seeing all the technologies emerge. It's always been just hospital estimates, and now we're starting to evolve into hospitals and hospital and physicians, and creating a subset of what we call that combined estimate. The challenge specifically as it relates to GFE, then it's these external physicians that sometimes within their communities, right, you kind of have a cat and dog relationship between, let's say, a hospital or a surgical center and external physicians. They want to, collaborate for patient care, but it's also hard to sometimes get into to combine their efforts on a single technology platform. And I think that's been one of the biggest issues is how do hospitals engage those external docs as a co-provider to get them to participate? Now, they don't have to do that yet. And we can talk a little bit more about this evolution of the GFE in terms of what they need to do today versus what's going to be coming down the pike. But I see that as being the primary challenge of why CMS came and said, let's just put a timeout on this, right? The technology needs to evolve in order to address this problem before we mandate, and enforce GFE.
Yeah. Yeah. I mean, one of the really hard things is historically you've had to say, oh, well, I have to switch EMRs or revenue cycle systems, and everybody needs to be on the same thing in order for this to work because we can only do it within whatever the hospital or kind of aggregating system is using. And that's, I think one of the things when I think about Payground is one of the things we're trying to tackle, which is, hey, we can provide a patient-centered experience. We can show the GFE, and you don't need to go through that really expensive, burdensome, painstaking process of switching out these major systems that you spend all this time and money getting in the first place. So we are trying to go build the payment network around how do we go make it easier and cost effective for a smaller provider and a bigger provider to go provide that capability. So that's, just from idea and innovation, that's one of the things that Payground's trying to bring to market. And of course, in partnership with Hive Health and what you guys are doing as well.
Yeah, well, I think that's what's key, right? Is that, to create that payment network, right? We're trying then to create that provider network so that they align.
That's right.
And, it's like we look at this of what happened like in the travel industry with like the Expedias of the world, right? Like, how do you create a centralized marketplace that allows for United, American, and Delta, or Hilton, Marriott, or Hertz and, Avis, all to participate in a centralized ecosystem where they all have their individual platforms, right? No different than, Cerner, Oracle, Meditech, Epic, from the clearinghouses perspective, or all the estimation tools. I mean, they're all very parallel to say if we can create a centralized market where everyone can come together despite all the differences and to be able to exchange information, like that to me was the only way that we're going to be able to address this GFE solution as we combine those together to create the good faith estimate, right? And then Payground's ability to distribute those payments back out. I think that's kind of the what gets me excited about the partnership.
Yeah. Yeah. Well, and so, we've talked about the GFE, can you maybe say, where are we at from a policy standpoint? It does sometimes feel like policy drives. You'd like to think that innovation alone and is going to drive it, but there's a policy aspect here. We're a couple months in, not even a month in, sorry, to a new administration. Have you, just being closer than most, are you seeing anything changing? Are we closer to a date where that's going to change, and maybe unpack that a little bit?
The short answer is yes. And I think that we have seen, I'm going to use the analogy of like tremors and the volcano erupting, right? Is that last year we had, I think it was April, that CMS put out kind of an update on GFE, specifically talking about kind of the integration technology, kind of getting into the differences, what was going on with the fire standard, what was going on with X12, things of that nature, right? That's just like, how are we going to communicate and share estimate information? To then another update in December, followed by a few weeks later, like a national webinar in the first couple weeks of January. And so I look at those, and the tremors are kind of getting, closer and closer together, that something is imminent. And I think that there's a general consensus Now, I've predicted this, for 3 years, and I'm 100% wrong, but that doesn't stop me from doing it again.
One of
But I
these days,
think,
you're going to be right.
yeah, at some point, right? At some point, you're going to be right. Even a broken clock is, right once a day, twice a day. So depends if you're using military time. Anyway, I digress. Sorry, but the point is that this enforcement, I think, is going to come. I think the Trump administration, they started the whole CMS price transparency. They're very much pro-transparency in what they're doing. And so I would suspect that sometime this year, CMS is going to make an announcement. They're going to kind of agree to the technology schema, which if you would have asked me last year, I would have said it would look like it was going to be fire. Right now, everything is indicating X12 using the claims remit, the 837, 835. And then they'll probably give the industry at least a year to prepare for that. So I just expect enforcement's probably, year and a half, 2 years out.
Sure. And so what, knowing we don't exactly know the timeline, but we do think there's something coming in the near horizon. What should provider orgs be doing now? How do you start preparing today so you're not just reacting? And then what benefit could you see ahead of policy? And just, hey, I've met the mandate of the legislation, which often feels like, I'm checking a box, but how can you get ahead of it and get, additional value out of it too?
Great question. Today, all providers, have to be giving a good faith estimate for uninsured and or self-pay. They continue to distinguish those, but it's only for that facility or that entity only, right? It's not the combined estimate where they're including external providers in that. So that's enforced today. But part of this going forward is then what we have found in implementing our GFE exchange platform is that this issue is more about process than it is technology. Technology, our system, all it does is just show that it's possible for a hospital to say, here's my estimate, and we're going to send our estimate out to surgery, pathology, radiology, anesthesia, and we're gonna simultaneously broadcast that out. And then those co-providers have the ability to kind of glue their estimate to it and bring it back in. What we've found over the last year and a half of implementing this, we've got about 125 hospitals on the platform today, is that it takes a long time to evaluate their current processes because they're not cut out for that. They're not ready to ask and answer the question, who else should be involved in this estimate? They're used to saying, the patient is coming to our hospital, we're going to give this patient our estimate, and then who else is involved with that? They're going to know the surgeon because that's where where the referral came from to begin with. But then the question is, well, what else is going to be done? And they need to be thinking about that now. And I think a lot have just kind of said, we're not even going to begin to think about that. We've even heard Epic say these words. We're not even going to begin to develop anything about this until we have visibility to enforcement. So to your point, it's all about evaluating the processes to get the information so that regardless of whatever technology they implement, they are thinking holistically about how do we create a comprehensive estimate.
Yeah, well, and once the patients start to see it, their expectation is going to start to change too, which is like, hey, I have this understanding now here, but I don't have it in other areas of healthcare. So that's going to raise the bar where if the technology exists, you could start to go expand it beyond just where you're required. So where do you see it going beyond just the policy, and could it be a catalyst for more reform initiatives, both government and just pure innovation?
Oh yeah, I think the good faith estimate, right? This even kind of ties into, I think, what the government's original intent was some of the CMS price transparency, right? Is to go publish all this machine readable file data. It's all self-reported. I feel like there's some limited use cases of that data, but in general, that data doesn't hold true to true out-of-pocket expectations for patients, for surgical cases, things like that. So it really falls flat where providers using their estimation technology, which has evolved over the last 20 years, is a lot better equipped to answer those types of questions. So I think what happens in this is that it's going to help create more evolution in patient estimates. I think that it will also challenge the type of information that's currently being shared through CMS price transparency. And I think it's going to help innovate in your space where you guys are, which is about then how do we get these payments, right? Because now all of a sudden when you give a patient, an estimate that says, well, it's $5,000, but that $5,000 is really broken out into these 5 different providers, right? Now that the challenge, which you guys easily address, is to say, patient, here's one place to go pay 5 different providers, where the majority of the industry is going to be sitting here that says, okay, patient, well, you have to go log on to the hospital's portal to pay them, the doctor's portal to pay them, and everyone else. And that's going to create a frustration that I think, again, providers need to be thinking about. How is technology answering the call in the payment place, the payment position? If we can answer, here's how to create the estimate, right? You guys are well positioned to say, and this is how patients can pay for the estimate.
Yeah. And we look at that as, the relationship dynamic changes, right? So this, hey, I need to get paid first, and I really care about how I'm getting paid. That's critically important. We can't lose sight of that. But once the patient has full visibility and they have access, now it's, well, I want different options around financing, around payment plans, around other types of bundling or subscription services that could be cross organization that didn't really exist before. It really leads the way for innovative providers to start to go say, okay, I want to think about how we're engaging our patients and how they're paying for our services differently, because that expectation is going to be set. And we think, there's a lot from just a relationship and a provider relationship and a network relationship management standpoint that's going to be a huge part of that. That even the policy only touches the very surface of what's required.
Yeah, well, I think we have to start talking about the elephant in the room, which is the total payment piece. I think there is some fear in the provider community about, if the hospital was just going to give a $2,000 estimate, now all of a sudden that hospital is given a $5,000 estimate because it includes all the other providers. Now all of a sudden there's this fear, well, that the patient's going to cancel. And it's like, we've heard this over the years with the initial hesitancy to give a patient an estimate because it was like, well, we don't want to lose the patient. I'm like, but do you really want the patient who's not going to pay? I mean, the patient wants to know what it's going to cost them, right? Even if that information is bad, they want to know. And then to your point, then the industry needs to be able to respond to say from a financing and a payments perspective, like how do we help the patient with that? But we're having a much more meaningful conversation, and it's going to reduce frustration and dissatisfaction by saying, look, the number's really 5,000. I know historically we've been talking about a 2,000, but now we've got the surgeon, we've got anesthesia, and we've got pathology, radiology involved here. And that's ultimately what drove having the no surprise billing. It's like, now that we've taken the surprises out of it, we're in a better position to engage the patient, I think, long-term overall.
Yeah. Yeah. And how, if any, just kind of jumping to your other big initiative that you have, how, if any, does the payer transparency play into that and the payer scorecard that you're?
That's almost a loaded question. I mean, so right now,
How much time do we have?
yes, we need to have a part 2 to this.
Yeah.
Is that payer dissatisfaction between payer and providers like at an all-time high, right? And this whole thing about payer accountability. And as it relates to the conversation around GFE, it was like this nice happy path to launch good faith estimates with self-pay and uninsured because we didn't have to involve the payers. And part of the challenge from a technology perspective is like, well, how are we going to engage the payers in this, right? And there's also this very strong belief in the provider community, right, that they shouldn't be having to even create estimates. They shouldn't have to be collecting from patients. It should be a payer responsibility because the member belongs to that. I'm like, I get all that. I can buy into that, but that's not the system that we live in, right? We have this patient payer provider tri-party, three-headed beast, and we have to work within that for right now. And so when these technology discussions over the last couple of years were coming about, is like, how are we as providers going to send, the payer, all these individual requests for, to create an estimate and then expect the payer to aggregate that and tell us individually and ultimately, more importantly, the patient what it's going to owe. And the thing I keep trying to remind providers is that the consumer experience is that I'm expecting to pay those where I'm getting the service rendered, right? Whether I'm getting my car fixed, getting the grocery store, filling up my gas, that's the exchange. And right now, consumers as patients and the last 20, 30 years have ingrained this, that the hospital is going to give them a bill. The technology started to point to payers telling the patient what they're going to have to owe the provider. And I don't know a single provider that has ever said, yeah, I want the payer to tell my patient what they're going to have to pay me. That's the whole reason why the patient estimation revolution happened 20 years ago, is because they realized they needed to have that conversation. And I think that's the other part that we're trying to solve, is to still let the providers own that and to communicate that and then to work with the patients, because right now the payers are out of that. And I know everyone philosophically wants to change that, but that's not our reality.
Yeah, we gotta make small incremental improvements, which is better than just trying to fundamentally change this massive system all at once, which is virtually impossible.
I have a lot of hope, about how revolutionary GFEs can be in this industry.
Yeah, we share that sentiment, which is why we have the partnership that we have. Is we share this philosophical idea that, it can transform it, and the technology and the process that's enabled by the technology can really transform how we pay for healthcare. So, Travis, maybe part one of many, but first guest on the Healthcare Payment Network podcast. Thank you so much. Any closing words?
No, I appreciate the opportunity. Thanks for the partnership and the thought leadership, about really trying to revolutionize, the industry. And I think that this is just the beginnings of that. And so I appreciate it. Thank you.
Thanks for tuning in to the Healthcare Payment Network podcast. We hope you found today's discussion insightful and valuable. Don't forget to subscribe, leave a review, and share this episode with your network. Stay connected, and we'll see you next time as we continue to explore the future of healthcare payments.